Hello, everyone. Welcome to SADS Facebook Live number 67 together here on this last Friday of June, June 25, 2021. I'm Mike Ackerman, genetic cardiologist at Mayo Clinic and director of Mayo Clinic's Winland Smith Rice Genetic Heart Rhythm Clinic and its complementary sudden death genomics laboratory. Here on behalf of the Sudden Arrhythmia Death Syndrome Foundation, the SADS Foundation, and our CEO, Alice Laura, it's great to have you join us again. I sure miss now that we've gone to every other week. It seems lonely on the weeks without you, but we have the next 40 minutes together. And whether you're here in the United States or anywhere across the globe, it is 9:20 p.m. in Israel, where hopefully, fingers crossed, Dr. Sami Viskin will be joining me in a few minutes. There's some technical difficulties in the background that Erin, the magician, is working as fast as she can to see if we can get Sami connected. And so I hope he'll be joining us. But if not, it'll be just us for some questions and answers. So get some questions ready. I really look forward to those. Those are beyond exciting for me. So if you don't know, and sometimes we forget, we're still in COVID-19 pandemic. And it's incredible to think we're probably 18 months now at the cost of 18 months and over 180 million individuals infected with the SARS-CoV-2 virus that causes COVID-19. Over 3.9 million deaths throughout our world. Here in the United States, we have over 33.5 million cases. And last week we crossed 600,000 deaths, 603,290 lives. Yesterday, there were 345 deaths alone in the United States. That number is way down, which is good, but we need to all be doing our part lest we get yet another wave. So do your part where it makes sense to mask. But if you're masking when you're driving alone in the car or when you're doing a live podcast in a corner of a room like I am, you got to ask yourself, what are you thinking? Now, this one I put on just to be able to show you Baylor University, Sikkim Bears, champions, men's basketball, also women's tumbling. So great, a shout out to Baylor. The other thing is get your vaccine. I got mine, as you know, in January. My wife got hers. 3 of our 4 children have theirs. So if it makes sense for you, and with very few exceptions, get vaccinated. We know that the vaccines are QT safe, they're Brugada safe, they are CPVT safe, ARVC safe, they are safe. We also know that the illness, for the most part, is safe if you are otherwise healthy. You don't have obesity, you're not obese, you don't have hypertension, you don't have diabetes, you're young and active. It is highly, highly unlikely that the virus will kill you. Your illness, your long QT, your genetic heart disease does not make you more vulnerable to the consequences of SARS-CoV-2 infection. So you are, and we've been saying it for 18 months, not at high risk from COVID-19. But all things considered, the benefits of the vaccine far, far outweigh the risk. There's no doubt. That's why I got it. That's why I'm very comfortable with my kids getting it. And I'm encouraging our second son to get his vaccine. Now, why are you hesitating out there? If you are, I get it. I know many of you have been hesitating because when I ask, there's been hesitation. There was the hesitation among my female patients because of the concerns about fertility. Myth, cruel anti-vax hoax. There's no basis for a fertility concern. Mayo Clinic put out an important piece debunking that myth back in December, and there's no reason to unbunk it or undebunk it. There's just nothing to that. What's the most recent one that is giving hesitation among the adolescents and young adults, especially the adolescent and young adult men? Yes, it's been the release of the vaccine-associated myocarditis, or where the vaccine itself, and these are the mRNA-based vaccines, of Pfizer and Moderna, where there is an increased rate of the vaccine causing mild inflammation of the heart, myocarditis. Is it true? Is this true? Yes. How strong is the signal? Un poquito. It's really weak, and it has been totally, I'm afraid, overblown in fake news media, overplaying the significance of this and causing a marked increase in vaccine reluctance among young men and young teenage males. The signal is stronger in the men than the women. That's why I'm separating those out. But we're still talking about a 1 in 40,000 person risk exposure. So, of the adolescent males and young adult males before the age of 29, those getting Pfizer or Moderna, it's about a 1 in 40,000 person. If you are that one, yeah, myocarditis doesn't sound good, but it has been weak expression, weak case in almost all of them. So, what's the likelihood that you will get the vaccine as a young male, get myocarditis, and end in the hospital for the myocarditis in the ICU? Well, it's about a 1 in, what was the numbers? About a 1 in a 40 million chance. So when I put everything in the risk benefit equation, the benefit of the vaccine still far outweighs the risk. I still recommend it to all of my teenagers and young adult males with any of our genetic heart conditions. Now, having said that, I think we're going to see some changes come down. I just had a patient last week, a young male, had natural COVID-19, had the natural viral infection, got one of the Pfizer vaccines, and the family was hesitant about getting the second one because it's been after the second shot that the increased risk has occurred. And we agreed together that the best course of action was to pause and not complete the second one. Now, that is not what CDC has said. That's what we decided together as patient, physician, patient, family, and physician. And it will not surprise me at all if eventually the CDC will come out and say, if you've had the natural SARS-CoV-2 COVID-19 illness, and then you got the first of the two vaccines, maybe you won't need the second one. So stay tuned for that. That is not CDC policy. That's what we did with one family, trying to make the best decision for that family, weighing the risks and benefits in the balance. Well, that's your COVID-19 update. Do your thing, do your part, get vaccinated. Remember that Delta thing? Have you heard about Delta? Not Delta Airlines, my favorite airline, but the Delta thing, as in the Delta variant. So the Delta variant is a mutated strain of SARS-CoV-2. I'm not sure where it originated, maybe the UK or India. I don't know, doesn't matter, that part. And it is much more infectious and contagious than the original SARS-CoV-2 strain. It has made its way to the United States, and about a week or two ago, the Delta strain the Delta variant accounted for about 1 to 2% of all SARS-CoV-2 infections. Now it's up to 25 to 30% already. Much more contagious. This is why we needed to get herd immunity and needed to get people vaccinated as quickly as possible and as fully as possible. The longer this virus gets to hang around, the more mutations it gets to do, and it's only a matter of time before we get a variant that is vaccine resistant. Thankfully, that is not true of the Delta variant. It is still, the vaccines work. So let's get vaccinated if you don't have a good reason not to. Well, that was a longer prelude. I was just trying to give Erin a little bit more time to see if she was able to work her magic, and they'll either post me in the comments that I'm going to fly solo for the next 30 minutes with your questions, or whether she's going to bring on Dr. Sami Viskin. My fingers are crossed, and I'll stay tuned right now to see what I'm doing next. Here we go. What do we find here live across the globe? Am I solo, or is the great Dr. Sami Viskin about to join me. Wow! I love it.
I couldn't join with my computer, and then I joined with the phone.
Oh, this is wonderful, Sami. I knew. I mean, Erin is amazing. She's really good, but I was starting to wonder. I thought I can't drag on this intro much longer before I'm going to have to take some questions that have come up, and there's some really good ones already. But
So
I'm
I
so
mean,
glad to see you, my friend.
so how many commercials did you pass?
Yeah, right. Well, let's jump in. I know we have 30 minutes together, Sami, and this, Dr. Viskin joins us from Israel. I think of you, Sami, often and your country with some of the things you all are enduring and going through. I hope you and your family are safe. Uh, Remind those, this isn't your first time on SADS Facebook Live, but just in case somebody might not know who I'm speaking with, give us a quick bio sketch of my dear friend Sami Viskin. How did you get from beginning to where you are now?
Me?
You.
No. Well, first of all, let me tell your audience. I just saw a paper that I was invited to review a paper about publications in long QT syndrome all over the world. And guess who is the author that has the largest number of publications on long QT syndrome in the world?
Arthur Wilda.
No, it's you.
Well, well,
Yes.
that must be some fake news going on.
Yes.
No, well, Sami, I do want to get into our topic of Brugada because you have made some huge impact. But no, I want our listeners who've joined us to get a sense of your little life career journey. Just give us a thumbnail insight into how you got started and how did the passion of genetic heart diseases in general and long QT Brugada, how did that all get ignited for you?
Well, I don't know how it started. I mean, I would just say a few words so we get started. So I deal with arrhythmias for many years. And many years ago, I read a few articles about longitudinal syndrome that got me fascinated, and I started working on that. So I'm associate editor on Circulation. I was associate editor in Heart Rhythm and in Europace. And, I do my best to, to cope with you guys. What can I say?
Well, I know last week or 2 weeks ago, Sam, we had a program devoted to CPVT and long QT and the role of ablation in ARVC. And we told them then, hold off all your questions about Brugada because I'll be joined on June 25th with Dr. Viskin. And so let's talk about Brugada and let's set the stage for a definition of what do you think, how would you tell our audience what Brugada syndrome is anyway?
Okay, so I mean, it is a genetic disease for which we can find a definite mutation in like 30%, that is in the sodium channel blocker. And for the rest, it is probably a polygenic disease. I mean, you have to have variants in more than one gene. Not one enough is enough to cause the disease, but only if you get several of them together, then you get the phenotype. And that is according to what we know. And we have this spontaneous disease, which are patients who have the spontaneous electrocardiogram, and then we have patients who only develop the electrocardiogram when they're challenged with medications. And this is where my views are different from the views of others, because I really think that the diagnostic challenge with sodium channel blockers to reveal the Brugada is not 100% specific. And just like with any other test in cardiology, you have false positive tests. And we still have to figure out how many of these positive tests are really false positive. And
Yeah.
and that is where I spend time writing. I have written editorials entitled "Everybody Has Brugada Syndrome Until Proven Otherwise," and I have
And
an editorial.
that Sami. In case people don't know your style, that's what we say tongue in cheek, right?
Yeah,
That
and another
you weren't
one,
being serious.
and the other one entitled "Read My Lips." Not every Ashmalin test it means you have Brugada syndrome, and here I have discussions with many others in the field.
Yeah. Let's work our way. How about we work our way back from the worst to the most asymptomatic. So, symptomatic patient has a cardiac arrest. They have Brugada syndrome. They're going to get a defibrillator, right?
Well, everywhere else except in Tel Aviv, they will. In Tel Aviv, we have been using quinidine to treat Brugada syndrome for many years. And this is really more the work of Bernard Belacen. I have taken the credit for him, but it's really his work. And when you think about the way the history developed, the long QT syndrome was described many years before the defibrillator was available. And that is the only reason why patients with long QT syndrome are treated with beta blockers and other medications, and they live for many years with medication without the defibrillator. And that is only because the studies on the effectiveness of drugs were available before the defibrillator became available. In the Brugada syndrome was the other way around. We first got the defibrillator for Brugada, and only later we started publishing our experience with quinidine. So we came a bit too late. But I see quinidine just the way you see beta blockers for long QT syndrome. I think quinidine is very effective for preventing ventricular fibrillation in Brugada, and you can use it even in patients with cardiac arrest. And we have published cases who had cardiac arrest and were treated with quinidine with no events uneventually. I mean, it's not easy, but I mean, Michael Vincent published on the use of beta blockers even for long QT1 patients who had cardiac arrest in the ancestral therapy, and he was happy leaving them on beta blockers. So that's the way I see quinidine for Brugada syndrome, even with cardiac arrest.
So let's assume that the most, and we'll come back to quinidine, but let's assume that just like a cardiac arrest survivor who has LQT2 or LQT3, we would not trust medicines alone. LQT1 cardiac arrest survivor, yes, I agree that if people were okay with the idea, I could make a LQT1 person very safe with either beta blocker or denervation, even if they started with a story of cardiac arrest. But the world, we still have a tremendous over implant of defibrillators going on everywhere. And so if we just spot an acceptability to implant those who are cardiac arrest survivors, I would actually be okay with that, because I'm not okay with the fact that we're still implanting asymptomatic long QT people, and we're implanting asymptomatic Brugada patients just because they have a positive Ashmalin test. That I'm on your crusade with. We gotta stop, or at least slow down a lot. But the survivor with Brugada gets a defibrillator, is having shocks. Quinidine makes great sense, but in one place, so Greg is asking the question that he was very symptomatic with his Brugada 5 years ago, and then he had an extensive ablation, and he's been episode-free since. And another person joining us says, what about ablation therapy? So can you give a couple thoughts in that high-risk Brugada person who's continuing to have episodes? Would you be quinidine first and then ablation? How do you see those two interacting with each other?
Okay, so let me tell you. So far, we have performed one ablation of Brugada syndrome. One.
Wow.
And that is because the rest are getting quinidine. So to me, it's quinidine first.
Yeah.
I mean, I absolutely recognize the role of ablation for Brugada syndrome in patients who have received shocks. I see that. I do not see the role of ablation in asymptomatic Brugada syndrome. I think that's wrong. You know my essay entitled "Don't Go Burning My Heart" about ablation of asymptomatic. But for patients who are getting shocks, I say quinidine first, and if that doesn't work, then Brugada syndrome. And I just received an email. Quinidine is sometimes hard to get in the world. There's a guy in Brazil who has Brugada syndrome, and he used to get so many shocks that he changed his address to live closer to the hospital so he could get to the hospital in Brazil whenever he would get the shock. He could not get quinidine in Brazil. So I buy quinidine, I put it in an envelope, I ship it to him by FedEx, and he has been shock-free for the last 5 years. He just wrote me to remind me that he has been shock-free for the last 5 years just because of quinidine.
So that white powder that you're sending through the mail really works.
Yes, it works. Yes.
So quinidine, a couple things though, you have tremendous experience with quinidine, probably more than anywhere in the world there in your program. Any tricks that you've learned to get around it may work great, but patients hate it in terms of its side effects, the GI distress and stuff. Have you learned some things that help minimize that? Because I think people give up on quinidine so quickly with the first round of diarrhea or something.
Yes. I mean, first of all, it's very important to swallow it with a full glass of water. I mean, if you look at the old literature, quinidine was the second most common cause for esophagitis, just for a local irritation from quinidine. So it's very important to swallow it with a full glass of water. Now, the diarrhea is a problem, I agree. And it is interesting that we don't even know what's the mechanism for quinidine-induced diarrhea. And I wish our colleagues in gastroenterology would work on that and tell us what is the mechanism of diarrhea caused by quinidine. Is there an ITO effect or something else? We don't know. At the end of the day, it is a compromise. People understand that a little bit diarrhea they have to tolerate. And I can tell you, I have, for example, one patient who was receiving shocks at night while asleep, which is a common thing in Brugada. And he could not tolerate quinidine even twice a day. But he takes quinidine once a day before he goes to sleep. And he has been shock-free for the last 4 years, even though he had many shocks before. So, it is a compromise. But I always say you have to take the largest dose that you can tolerate, and you are the only one who can decide what is the definition of what you can tolerate or not, because it varies from individual to individual.
Yeah, but drink it with a large glass of water is one thing that can be helpful. And have you found other things at all that have, so I guess let me ask it a different way. Of all of those patients of yours on quinidine where you and they are weighing the side effect package in the balance and the upside, the therapeutic goal in the balance, what percent of your quinidine treated patients are you having to wave the white flag on quinidine and say it's not going to work, it's not agreeing with the patient?
Yeah, so it's 30% that eventually they throw it out.
30%?
30%, yes.
Yeah.
I mean, the problem is for real, and I wish we could find a problem. And I keep telling our friends in gastroenterology to look at the mechanism of the diarrhea induced by quinidine, because it is a problem.
Yeah. So for those who are tolerating it, it works great. And let's take it to the question that Serena is asking us, Dr. Viskin. She says, do asymptomatic Brugada patients need to be on quinidine prophylactically? And let me preface that by saying, so it's not somebody where we don't know they have the diagnosis. Let's say you and I agree this person really is Brugada. They give us the Brugada pattern spontaneously. They've never had a symptom. Do I need to put that patient on quinidine preemptively, prophylactically? I'll let you answer, and then I'll tell you what I've done over the last 20 years and see if we're close to doing the same thing.
Okay, so I do, because I mean, what we know about the risk for this asymptomatic, we can debate a lot, and you know, I published a paper on the risk for asymptomatic patients. And I mean, what we know for today in 2021 about the risk for the asymptomatic patient is that his risk of having a spontaneous arrhythmia is in the range, is less than 1% per year. This 1% per year is based mainly on patients who had implanted defibrillators and got shocks. And that does not mean by any means that without the defibrillator they would have died. So what we can tell our patients is with asymptomatic spontaneous Brugada is that the risk is less than 1% per year, which is less than 10% in 10 years. But we do not really know less by how much. Now, we can argue if this is high risk or low risk. And my common practice is, before I tell my patients the numbers I know about the risk, I ask them, what do you think is high risk enough or low risk enough? And let me tell you, the numbers they give me are much lower. Before they hear the numbers I want to tell you, they're not happy with 1 in 1,000. I mean, the numbers are very scary for them. So for the asymptomatic spontaneous type 1, I think it is fair enough to prescribe quinidine just in the same way we prescribe beta blockers for the vast majority of patients with asymptomatic long QT syndrome. I know your work about patients who made it to adulthood without arrhythmias, who do not have a very long QT, and who can say without therapy. But you will have to agree with me that the vast majority of patients who you and I would agree have asymptomatic long QT syndrome would go on beta blockers. And then if they develop side effects, then we can discuss it again. So that's the way I see it in quinidine, because, I mean, quinidine has about reputation about its pro-arrhythmic events, about causing arrhythmias. The literature on pro-arrhythmia from quinidine is based on women who rarely have Brugada syndrome and on patients with organic heart disease. Is a different population. For a male with no heart disease, the risk of pro-arrhythmia for quinidine are very small. Yep. And that is why I feel very confident in prescribing quinidine for asymptomatic spontaneous type 1. The drug-induced type 1, I leave them alone.
Yeah. Yeah, I think it's quite, like you said, it's kind of interesting how the long QT journey and the Brugada journey, they start from different points of knowledge and understanding, where everybody with long QT got put on therapy. And now it takes until 2021 until we publish a first paper called Intentional Non-Therapy in Long QT Syndrome with Preventative Measures Only. On the flip side, for Brugada syndrome, for the last 20 years, I've been doing intentional non-therapy with preventative measures only. for the vast majority of my asymptomatic Brugada patients. And now, 20 years later, starting to wonder, should I be putting them on quinidine prophylactically? And I can only say, now you take care of way more Brugada patients than I do, but of my asymptomatic Brugadas who we have done preventative measures only with them, we haven't had a single conversion in 20 years of any of those patients. And so the risk is low. The risk has been thankfully really low in our program. But you're right. It's one where we started with prophylactic therapy in everyone with long QT, and in Brugada we have largely done no therapy at all until you have your first spell, and then we're going to throw in a defibrillator.
Yeah.
So it's just it's fascinating how the two, the chronologies of the two.
I keep telling my fellows, we keep treating our last patient.
Well, let's look at this. Speaking of the last patient, let's look at Sarah's son that she's sharing with us, because I think this will give an important point for you to make. She's asking for her 13-year-old son who has a spontaneous ECG. Somebody did an EP study and it was negative, for whatever that's worth. Has a loop recorder, and she's asking, when should he have an ICD? And I guess the reason I want you to address this question is, I think these families need to know that an ICD is not an absolute element in the destiny of their child. That if we do this right, her son may never need, and potentially you could argue should never need, an ICD. Do you want to expand on that?
Yeah, absolutely. I would never put an ICD in asymptomatic patient before trying quinidine. I mean, our experience with quinidine is very good. We never had proarrhythmias with quinidine in this population. It's the proarrhythmia from quinidine is a different one. So I can understand if they get diarrhea, if they get adverse events from liver problems or whatever, then okay, we can discuss ICD. But I would never discuss ICD as the first treatment for asymptomatic patients, certainly not in a child where the complications from an ICD are expected to be greater than from an adult, just because he has to be with the ICD for the last 70 years, and he will need replacements, and he will grow up, and he will need replacements and device replacements. So the question is when to start quinidine. If he should start now, he should wait a little bit. I would argue that it is very rare to have arrhythmias in a child, and I would wait till the age of at least 20 years and then start thinking about starting quinidine. I mean, it has a lot to do with how impactful his baseline ECG is, but ICD in a prophylactic in a child, I would not do.
Right, and I think one of our attendees, and I won't pronounce her or his entire name. I think it's her, La Gordita. She's just emphasizing what you've been saying. A doctor told her husband to stop the quinidine, and he got shocked 2 weeks later from his Brugada substrate. So I think, you have been right on this for so long, and I think it's time that the Brugada specialists, we start figuring out how to learn how to use quinidine and how to work with patients to help them tolerate it better. But would you go so far as Julia's question? She's saying, if someone's fitted with a subcutaneous ICD, somebody gave them an SICD, no cardiac arrest, has been shock-free, would you go so far to recommend getting that defibrillator removed and switching over to quinidine?
Well, as a rule, I never remove the defibrillator. I leave them as a gift, as a reminder of a wrong decision taken many years ago. So I would not remove them. But
see, that's interesting, Sami, because I'm completely the opposite. I tell my patients I'm not beholden to any treatment decisions that somebody made for you in the past. So if I don't think you need it, I don't feel obliged to keep this as part of your history package deal for the rest of your life.
no, I see that, but it's a new surgery. I mean, why just don't leave it alone? I mean, the
Oh,
batteries will go off and will stay down forever. You know, I have patients who have defibrillators that have been there for years and they're off. I mean, they have no batteries, but they're still there. I
okay.
mean, so
Yeah, so you
I'm
leave it
saying,
off. You don't insist on the batteries out, the battery's done, let's put in a new one because
oh
somebody put
no,
in an old one.
no,
Yeah.
absolutely no. I always say, whenever you need to replace a defibrillator, you have to ask yourself, would you put it if you didn't have it? Because the most the most dreadful complication from a defibrillator is the infection, and the chances of getting an infection is much larger with a replacement than with the first implant. So in order to replace a defibrillator, you really need to be convinced that you need it. Otherwise, I would not replace it. And especially if you have the option of drug therapy.
Yeah. So that's a really important point because I have tended towards, if you basically are saying I'm going to abandon the ICD, and we have patients who are like, I want everything out. If you never thought I needed it in the first place, I don't want any metal in my body as a reminder of somebody else's decision as to what they thought I needed. So again, we have left them behind, just like you. I haven't quite used the gift analogy for why we'll just leave it behind and ignore it. I might have to borrow that one from the great Sami Viskin as another way of telling the story.
Well, it has a lot to do with how long it has been implanted.
Yeah.
Because if the leads have been in place for 5-6 years, then attempting to remove them has risk. And then if you only remove the defibrillator and leave the leads in place, you risk. There is a small risk of infection just because you're opening the wound for the second time, and you can get the pocket infected even though the device is out. The leads are still there because you didn't want to explant them because they've been there for 6 years and there's some risk involved. So that is the main reason why I just leave them as a present, as a reminder that doctors make mistakes.
Well, I'm gonna have to chew on that one myself because I might need to leave that option better on the table because I think you're making a really interesting point there. I'm just scanning on the sidebar as time is running out on us. It went way too fast. And let me give you the final one. Should asymptomatic, let's do two, rapid fire. These are two really good ones. Greg is asking if their child owns the Brugada mutation, never a symptom, are you putting in loop recorders just in case, just to monitor for spells?
In some of them, at present time, the technology is for 3 years. So at some point I try to wait so I don't put it too early. There is a role for implantable loop. I see that. And I caught arrhythmias in asymptomatic patients with loop recorders in a few. So the question is not to whom, but really when.
Yeah.
So I try to wait to the right age.
Yeah. I use them. I don't use them very much, honestly. I find a nice place for them is when they have a quasi spell that I'm quite sure had nothing to do with their heart. But then
Yes.
I tell them, you just had strike one. I don't think it's anything, but next time we won't be relying on just my brain. We're going to put this rhythm spell correlator in place.
Absolutely. I do the same. If they have a vagal syncope that I think is not related, I put it right away. So next time, we will not have the same discussion. Absolutely.
Serena gets the final one, and thanks to all of you who've joined us for really some great questions for Dr. Viskin. It's this one. What about asymptomatic fever-triggered Brugada? Do you put them on quinidine? So they don't have a spontaneous pattern at rest. It only comes out with the fever. Are they quinidine eligible, or are they more like your agmaline positives and you stand down and keep quinidine on the sidelines?
Okay, our own experience is they do very well. I do not put them in quinidine. I mean, I am aware of the multi-center study by Arthur Wilde where patients had arrhythmias. What we do is we do repeated holters, 12-lead holters with high electrodes, just to make sure, I mean, at least twice a year, to make sure they don't have a spontaneous type 1. Once they do, they go on quinidine. If they don't, we do not leave them. We do not really have many patients, but so far, in our experience, they do very well without therapy.
Great. Well, as they say, that's a wrap. So we've wrapped up SADS Facebook Live number 67. And whether you all have joined us on Facebook or YouTube or Twitter, this has been Dr. Sami Viskin, a dear friend of mine from Israel, one of the greats in our field of genetic heart rhythm diseases, and a great guy. Sami, I wish you and your family well. And I can't wait to see you live and not vis-a-vis a Zoom meeting. So be well back down there. And for all of you listening, thanks for joining. You know, we've moved to every other week. And so enjoy your 4th of July weekend here in the United States on July 2nd. And then we'll be back together on July 9th with Dr. Rachel Lampert from Yale, talking about the defibrillator and the athlete. Can the two coexist? And I'll give you a sneak peek at the answer. Yes, they can. So see you in 2 weeks. Take care, everyone.